In a case study by Taluska, Jeter, and Ganguly, a 35-year-old female with past medical history significant for anxiety and depression presents with complaints of headaches that have been worsening for over 3 years. She reports that the pain starts in the back of her neck and moves to the forehead. The pain is described as a tightening band around her forehead. The characteristic of the pain has been the same over the years, but the frequency has increased. She does not have any associated symptoms such as nausea, vomiting, blurry vision, photophobia, or photophonia. She is single and works as an attorney at a prestigious law firm. She uses aspirin and Tylenol, which provides some relief.
So how do we diagnose a tension-type headache? The diagnosis of tension-type headache is accomplished by reviewing the patient's personal and family medical history, as well as conducting a general physical and neurological examination. At times, it can be difficult to distinguish between a tension-type headache and a migraine attack. Here is a difference between the two. Patients with tension-type headache usually does not accompany features like nausea, vomiting, photophobia, phonophobia, and osmophobia, and the pain is not aggravated with movement. This approach is what separates it from migraine, which has the presence of these features. The pain in tension-type headache is characterized by a bilateral tight band-like discomfort and is non-throbbing in nature. It has an onset that is gradual with a duration of minutes to days and may persist with mild fluctuations for weeks or months. While the pain in migraine is usually unilateral, throbbing in nature, sudden in onset, and has a duration of 2 to 24 hours or longer.
Tension-type headache is very common, with a lifetime prevalence in the general population ranging in different studies between 30 and 78%. While it was previously considered to be primarily psychogenic, a number of studies since ICHD-1 or the International Classification of Headache Disorders strongly suggest a neurobiological basis. The division of tension headache into episodic and chronic types introduced in ICHD-1. In ICHD-2, the episodic type was further divided into an infrequent episodic tension type and frequent episodic tension type. Infrequent episodic tension type occurs in almost entire population, usually has a very little impact on the individual, and in most instances requires no medical attention. At least 10 episodes of headache occurring on less than 1 day per month or less than 12 days per year, lasting from 30 minutes to 7 days. For diagnostic criteria, at least 2 of the following 4 characteristics must be present: bilateral location, pressing or tightening or non-pulsating quality, mild or moderate intensity, not aggravated by routine physical activity such as walking or climbing stairs, or both of the following, not associated with nausea or vomiting, although photophobia or phonophobia may be present. Frequent episodic tension-type headache, usually associated with considerable disability and sometimes warrants treatment with expensive drugs. At least 10 episodes of headache occurring on 1 to 14 days per month on average for more than 3 months, or 12 or more and less than 180 days per year, lasting from 30 minutes to 7 days. For diagnostic criteria, at least 2 of the following 4 characteristics must be present: bilateral location, pressing or tightening, non-pulsating quality, mild or moderate intensity, and not aggravated by routine physical activity such as walking or climbing stairs, or both of the following, no nausea or vomiting, no more than one of photophobia or phonophobia. Chronic tension type headache. It is a serious disease causing greatly decreased quality of life and high disability. Headache occurring on 15 days per month on average for more than 3 months or 180 days per year, lasting hours to days or unremitting. For diagnostic criteria, at least 2 of the following 4 characteristics must be present: bilateral location, pressing or tightening, non-pulsating quality, mild or moderate intensity, and pain does not worsen with routine physical activity such as walking or climbing stairs, or both of the following: no more than one photophobia, phonophobia, or mild nausea, and neither moderate or severe nausea nor vomiting.
For the epidemiology, in terms of age and sex, tension headaches are more common in women than in men. Infrequently, it begins in childhood or adolescence but are more likely to arise in middle age and to coincide with anxiety, fatigue, and depression in the trying times of life. According to a study, the average age of onset is 25 to 30 years old, and the peak prevalence occurs between ages 30 to 39 years and decreases slightly with age. As for the incidence, tension headache is greater than that of migraine. In a Danish epidemiologic follow-up study, the annual incidence for tension type headache was 14.2 per 1,000 persons. According to Lance and Curran, about one-third of patients with persistent tension headaches had readily recognized symptoms of depression. Also, Patton has noted that not more than 1 or 2 patients out of every 1,000 with tension headaches will be found to harbor an intracranial tumor, and its discovery has been most often incidental.
The following are possible explanations of the pathophysiology of the tension headaches according to Adams and Victor's Principles of Neurology 11th edition. So the first is the excessive contraction of craniocervical muscles and an associated constriction of the scalp arteries. However, it is not clear that either of these mechanisms contributes to the genesis of tension headache, at least in its chronic form. And in most patients with tension headache, the craniocervical muscles are quite relaxed by palpation and show no evidence of persistent contraction when measured by surface electromyographic recordings. Another is the hardened pericranial and trapezius muscles as reported by Sakai and Associates using a laser device. And lastly is that nitric oxide creates a central sensitization to sensory stimulation from cranial structures, in which the strongest support for this concept comes from several reports that an inhibitor of nitric oxide reduces the muscle hardness and pain in patients with chronic tension headache. So at present, all of these are interesting but only speculative ideas.
Here's the clinical manifestations of patients suffering with tension headache. So where is it manifested? The site of tension headache is generalized, but it is usually bilateral with occipitonuchal, temporal, or frontal predominance or diffuse extension over the top of the cranium. Now, for its clinical characteristics, pain is usually described by the patient as dull and aching, but questioning often uncovers other sensations such as fullness, tightness, pressure, or a feeling that the head is swollen and may burst. Or in layman's term, patient will simply say that, "Dok, akong feeling bitaw kay murag nang hubag akong ulo dayon, magyud siyang mabuak sa kasakit." Also, pain develops soon after awakening. But if the patient will report with persistent throbbing quality of pain, nausea, photophobia, then other diagnoses might be considered since these are absent in tension headache. So good history taking is really important to narrow different cases. As for the urinal pattern, the onset is more gradual than migraine, and the headache, once established, may persist with mild fluctuations for days, weeks, months, or even years. That's why its life profile ranges from 1 or more periods of months to years. So what factors trigger tension headache? These include fatigue and nervous strain, and these are associated with depression, worry, and anxiety.
For the pharmacologic treatment, pain can be generally managed with simple analgesics such as acetaminophen, aspirin, or other NSAIDs and may be helpful if only for brief periods of headache. Persistent or frequent tension headaches respond best to anxiolytic or antidepressant that is used cautiously. Thus, amitriptyline is the only proven antidepressant that is effective for chronic tension headache. We have to remember that stronger analgesic medications should be avoided. There is also a report on the success of treatment with calcium channel blockers, phenelzine, and cyproheptadine. Triptans alone for tension headaches are not helpful, but are effective in tension headaches when the patient also has migraine. This is also applicable for ergotamine and propranolol if symptoms of both tension headache and migraine are present. So what are the non-pharmacologic management? Behavioral approaches such as relaxation techniques can also be effective in teaching patients how to deal with underlying anxiety and stress. Some patients respond to ancillary measures such as massage and meditation to relieve pain and stress. Biofeedback techniques can also be effective as well for some patients. This therapy ought to eliminate or reduce the intensity, duration, and frequency of their tension headaches. Gradual withdrawal of daily doses of analgesics, ergotamines, or triptan medications is an important aspect of treating chronic daily headaches.
Another non-pharmacological management is cognitive behavioral therapy. Since patients with tension headache commonly associated with depression and anxiety, this management is very helpful. This is a type of psychotherapeutic treatment that helps people learn how to identify and change destructive or disturbing thought patterns that have negative influence on behavior and emotions. And then we also have acupuncture. This therapy is effective for treating frequent episodic or chronic tension type of headache.